Hi, welcome to Ruddle on Retreatment. Today we're going to discuss the non-surgical removal of 4 obturation materials commonly encountered in endodontic failures. These materials are Gutta-Percha, silver points, carrier-based obturators, and paste fillers. For over 20 years, my professional life has been intensively divided between clinical practice, education, and research. As a clinician, 90% of my time is spent performing endodontic retreatment, which typically involves removing one or more of these materials. Today we'll look at the best retreatment techniques and actually show you how easy it can be to remove these materials from teeth. However, before we begin, it is imperative that we understand why cases fail. Any clinician who three-dimensionally cleans, shapes, and packs root canal systems has to be staggered by the significant variation in anatomy from tooth to tooth. These differences appear as lateral canals, bifidities, trifidities, deltas, fins, cul-de-sacs, anastomoses, and so forth. When we look back at how we have practiced endodontics over the last several decades, a time when we didn't have techniques and materials to address all the possibilities of these anatomical variations, it is no wonder that there would be some failures. Today, most of these failures can be attributable to one single overriding factor: leakage. Leakage can usually be traced directly to our inability to adequately clean, shape, and fill root canal systems. In this maxillary right first molar, the Gutta-Percha is underfilled and vertically underextended. There's frank apical pathology. In this mandibular right first molar, a silver point binds over length in the mesial canal, an example of silver point overextension and internal underfilling. The mandibular right first molar is an example of a carrier-based obturator failure. Notice the underprepared mesial root does not allow for Gutta-Percha to flow to the terminus. This mandibular left second molar is poorly obturated with a paste filler. The result is leakage and apical pathology. Some cases exhibit multiple obturation materials in the same tooth: silver point in the mesial root, paste in the distal root, frank apical pathology with a furcal blowout. A mandibular right terminal bridge abutment exhibits 3 posts, canals packed with Gutta-Percha, and frank apical pathology. Finally, coronal leakage is a significant factor in endodontic failure, and this case demonstrates a variety of poor concepts. In endodontic retreatment, it should be appreciated that there is never just one set of problems. There are a multitude of circumstances that need to be addressed to ultimately obtain successful outcomes. Celebration of removal of an obstruction must be restrained because below the obstruction there may be a perforation, block, ledge, or other problem. We need to start thinking in terms of retreatment that there are multiple sets of issues to be dealt with in an incremental fashion to be successful. When we evaluate cases involving retreatment, it is essential that we discuss the technical aspects of the treatment in a candid fashion with the patient. This should include not only the realistic long-term prognosis, but also what to expect during treatment and after a working visit. Retreatment cases can often flare up and create exacerbations where the patient can actually get worse before they get better. In some cases, antibiotic regimens, leaving a tooth open, anti-inflammatories and narcotics in concert may be necessary to ensure patient comfort. I have found that the better the communication with the patient about what to expect, the better the outcome for both patient and the clinician. Okay, hopefully you have a better understanding of why cases fail. A little later, I'll discuss with you some numbers relating to endodontic prognosis which may surprise you. Currently, there is a massive number of endodontic failures. Therefore, a phenomenal possibility is present for you to train up so you can position your practice towards personal satisfaction, growth, and profitability. At this point, you may be asking yourself a number of questions, such as, can I do it? What kind of training would be necessary for me and my staff? How long would it take to become proficient? Am I equipped? Is it profitable? The answer is simple. You can successfully, non-surgically retreat a significant number of these cases in your office with the proper techniques and a few basic tools. Well-angled films are an absolute prerequisite in dealing with any endodontic situation. I have found that digital radiographic systems deliver superior images with 90% less radiation and have a range of features, such as the ability to enlarge any area of the image for inspection, colorization to show differences in opacity, and reversed image capability. A software package is also available to show pixel density, so you can take the mouse and move an icon around the root, and if there's a lesion, the discrepancy in the numeric reading indicates the loss of bone density. I have found this to be an invaluable diagnostic feature. Probably one of the greatest advantages of this type of radiography is the ability to leave the cassette in the patient's mouth, and because the image appears on your screen in 3 seconds, you simply move the cone to another angle and take additional images without removing the cassette and disturbing the original orientation. This is a common problem with standard X-ray devices. Digital systems are chemically free, archival, teleportable for conferencing or insurance documentation, and you can even create a real-time thermal print to hand to the patient. Of course, standard X-ray systems will work well with careful attention to proper angles, settings, and darkroom techniques. The dental operating microscope is a critically essential part of the armamentarium in non-surgical retreatment. In my experience, Carl Zeiss has a line of superior products. Specifically, the Pro Ergo has magnetic clutches. This feature, in conjunction with rotatable and inclinable oculars, allows us to get into great position for patient care. Doctor stools are important with the armrest feature because it allows us to have shoulder support and lumbar support so we can be comfortable during our procedures. The pistol grip handles allow us to adjust the light intensity, focus, and the zoom feature. The P5 piezoelectric ultrasonic unit provides unmatched power when performing endodontic treatment and retreatment procedures. This unit affords precise working accuracy and a broad power range, and its unique feedback system enhances safety by automatically regulating tip movement. The Pro Ultra Endo 1 through 5 tips are made of stainless steel and then externally coated with a zirconium nitride abrasive. These ultrasonic instruments can be introduced into small spaces while enhancing vision, improving performance, and expanding clinical possibility. The zirconium nitride coating enhances durability and enables the instruments to sand away materials during endodontic treatment and disassembly procedures. The Pro Ultra Endo 6, 7, and 8 ultrasonic instruments are made of titanium to provide clinicians with thinner diameters and longer lengths as compared to the Endo 3, 4, and 5 instruments. The smallest working ultrasonic tips are 10 times smaller than the smallest round burrs. This reduced size translates to more control when brush cutting away minute amounts of dentin in a very precise manner. The Pro Ultra Endo tips are designed with contra-angle bends. With these tips, we can trough for MB2s, we can chase for calcified canals, pulp stones can be disintegrated out of the pulp chambers. All types of materials can be removed with these versatile instruments, from Gutta-Percha and paste to post and broken instruments, all with a minimum loss of tooth structure. As you will see, ultrasonics will play a key role in all of our retreatment procedures. These are the essential tools you will need to retreat most failing cases. The more specific items, such as appropriate burrs, ultrasonic tips, files, chemicals, and other devices, will be discussed in each material segment. Now that we have the general picture, let's develop our game plan for the removal of each material. There are a variety of techniques that may be utilized to remove Gutta-Percha. Of these options, the best techniques for a specific case is selected based on preoperative radiographs and clinically assessing the diameter of the orifices after re-entering the pulp chamber. Certainly, a combination of methods is generally required based on the length, diameter, and curvature of any given canal. Profile orifice shapers are 19 millimeters in length, have 10 millimeters of cutting blades, and may be used to effectively eliminate gutta-percha from the root canal system. Orifice shapers are available in a variety of tip sizes and tapers. Profile 04 tapered rotary instruments are available in 21, 25, and 31 millimeter lengths, and are also very effective in removing gutta-percha from a longer length canal or in the apical 1/3 of a canal after using orifice shapers. Shown here are the 20, 25, 30, and 35 04 tapered instruments. Rotary instruments should be used between 900 and 1200 RPM to generate sufficient speed, friction, and heat to mechanically soften and auger gutta-percha out of the canal. The plastic block demonstrates how effective rotary instrumentation is at removing gutta-percha. Initially, in the coronal 1/3 of the canal, we select an appropriately sized orifice shaper that is slightly smaller than the preparation, and we use sufficient speed so that we thermal soften the gutta-percha and auger it out of the canal. Sometimes rotary Profile 04 instruments are used to go deeper into the canal to remove the apical portion. The speed or RPMs of the rotary instrument needs to be sometimes 3 to 4 times that which is recommended for shaping procedures. The 5004 touch and heat may be used as a heat source to thermal soften and remove bites of gutta-percha from previously packed canals. The unit is equipped with an intensity dial that regulates temperature up to a maximum setting of 1200 degrees Fahrenheit. When this device is activated, heat is transmitted to variously sized heat transfer instruments. The System B is another alternative when selecting a heat transfer device. When removing gutta-percha from canals, the temperature setting should be 600 degrees Fahrenheit. The P5, as seen earlier, is yet another device which can be utilized to impart heat and thermal soften gutta-percha, this time through an appropriately sized ultrasonic tip. In this model, you can see yet another way to remove gutta-percha. The System B is utilized, plunges into the gutta-percha to impart heat, and then a headstrom file is selected, typically size 35, 40, or 45, and is gently wound down into the thermal softened gutta-percha. When the gutta-percha is frozen on its cutting flutes, at times the entire cone can be removed in one fell swoop. The file and solvent removal option is best utilized to remove gutta-percha from smaller diameter and/or curved canals. Small K-type files are used to pick into chemically softened gutta-percha. Chloroform is the reagent of choice and plays an important role in chemically softening the gutta-percha. Gutta-percha and most sealers are miscible in chloroform and, once in solution, can be absorbed and removed with appropriately sized paper points. Drying solvent-filled canals with paper points is known as wicking and is always the final step of gutta-percha removal. An extracted mandibular molar will be our first case example. My first choice for gutta-percha removal is rotary instrumentation. Rotary provides the safest, easiest, and most predictable way to remove gutta-percha if sufficient canal shape exists. The size of the canal shape is best determined by radiographs and visualizing the size of the orifices at the completion of the access cavity. Surgical linked round burrs are useful because it kicks the head of the handpiece further away from the occlusal table and allows unobstructed vision of the burr when working. Gutta-percha can be removed from the pulp chambers of teeth with surgical length carbide number 2, 4, and 6 round burrs using very slow RPMs. I like to use a diamond that's tapered to true up the axial walls so there's a flare from the pulp chamber floor to the occlusal table. This is a great starting point for removing gutta-percha from the roots. I have found at times that if you're pushing too hard, probably you should consider increasing the RPMs because that'll generate more friction, more heat, and more successfully bring the gutta-percha coronally. The instrument kind of floats into the gutta-percha, and it's interesting to see how it so efficiently spirals out of the canal. The instrument will kind of walk around the periphery of the canal and will tend to engage the gutta-percha and bring it occlusally. I like to remove gutta-percha progressively in a coronal to apical direction, removing the coronal 1/3 first. The middle 1/3 would be removed second, and again, smaller instruments will probably be required to reach deeper into the canal if space permits. It's not unusual at the conclusion of using rotaries to find gutta-percha in isthmus areas between MBs and MLs. In this instance, we can use small, specially designed ultrasonic instruments, and we can gently brush cut away minute amounts of dentin to further gain access to gutta-percha that's harbored in this isthmus area. Oftentimes, after optimal use with rotary instruments and ultrasonics, small amounts of residual gutta-percha are best removed with chemicals like chloroform. The tooth can be flushed brim full and flooded with chloroform, which will enhance the chemical softening of any remaining gutta-percha that would lie in the fins or anastomosing between systems. Paper points would then be stirred and carried into the canals, and by using this particular action, you can see that it's pretty successful at freeing up and liberating residual cements and gutta-percha up into the pulp chambers of teeth. Constant flushing and flooding the canals with solvents is the most successful way to eliminate remaining gutta-percha in the very difficult and inaccessible areas. Oftentimes when we bring paper points out of canals, we can see the pink gutta-percha on their working ends, which is a tip-off to the clinician that more flushing and more paper point wicking is necessary. I like to flush the canal and aspirate, irrigate, aspirate, irrigate, aspirate, and this flushing action improves removing residual gutta-percha out of complexities within the canals. At times, after clearing out the pulp chamber, residual gutta-percha will be seen even after good clinical efforts. It's important to retrace the steps using chemicals and paper points through wicking activities to prepare cases for subsequent shaping, cleaning, and three-dimensional filling. In this clinical video, let's look at removing gutta-percha utilizing the heat removal option. The heat carrier selected is smaller than the cross-sectional diameter of the orifice. Remember to remove gutta-percha progressively, crown down. Activate, plunge, deactivate, and allow the tip of the instrument to cool, which will typically freeze a bite of gutta-percha on its working end. Many times, because of failure, canals have been underprepared and there's a limitation to how far you can take the heat transfer instrument. In those instances, we select rotary instrumentation as we've previously described. Subsequently, the canals are flooded with chloroform and paper points are used in the wicking technique. We wick the canals until the paper points are clean, white, and dry. Clinically, we can take advantage of the in vitro situation and we can plunge in with a System B heat plugger. You can kind of stir the plugger around to generate maximum heat into the gutta-percha. Being careful though, not to leave the activating device on for more than just a few short seconds. But once the gutta-percha has been sufficiently thermo-softened, we can select the 45 headstrom. It can be gently wound down into the thermo-softened mass. At times, looking down into the chamber, we'll see space between the gutta-percha and the headstrom, and a plugger is used to pack the cooling gutta-percha around the flutes of the headstrom so that we can maximize retention. Turning the headstrom a quarter, a half, or a full turn draws the headstrom down into the thermal-softened mass, which ensures that the gutta-percha is engaged and removed. Chemicals and files have been used historically to remove gutta-percha around canal curvatures, in canals that are very restricted in their cross-sectional diameters, and in canals where easy access with rotary or heat is not available. We select 10s and 15 files to gently pick into the canals, which carry solvent deeper into the Gutta-Percha. By chemically softening the Gutta-Percha, then we have an opportunity to follow up with larger files which don't work any further than the pilot file and begin to remove material laterally from the canal walls. It's critically essential to remove Gutta-Percha in a crown-down fashion so that we don't inadvertently push chemically softened Gutta-Percha periapically. Use small files to pilot and work gently into the mass. Larger files work to that level but work lateral, and they allow more irrigant, in this case chloroform, to work out laterally. It's common to notice the material coming up in the pulp chamber, which supports the need to flood the canal with chloroform again. Sponges are available to plunge the files into and clean their flutes so that we can reintroduce them in a clean way. Top the tooth off with chloroform and use smallest, most flexible pre-curved files to negotiate the terminus. Check the tip of the file continuously to see what's on its working ends. If it's Gutta-Percha, continue to work in a solvent-filled canal, always following up with wicking procedures until the paper points are clean, white, and dry. Earlier in the show, we saw this particular case. This radiograph of an endodontically failing molar shows the previously treated canals are underfilled and underextended. I removed the crown, established straight line access, and almost immediately identified an MB2 system. Rotary instrumentation was utilized to auger the Gutta-Percha out of the palatal, DB, and MB systems. A subsequent photograph shows the pulpal floor and orifices following canal preparation procedures. You can see the chamber is an opening for packing the tooth in 3 dimensions. The post-operative radiograph demonstrates non-surgical retreatment has addressed the root canal system. This right central incisor exhibits post-treatment disease. We can visualize inadequate endodontics, resorption, and apical 1/3 pathology. A photograph demonstrates access, the exposed Gutta-Percha, and a 45 headstrom inserted into the thermal-softened mass. Another photograph reveals the headstrom mechanically removing the heat-softened single cone of Gutta-Percha. Here we see the position of the hemorrhagic resorptive defect. This photograph shows a portion of the recleaned and shaped canal and better visualization of the defect. A cone-fit film demonstrates space for the injection of warm Gutta-Percha to enhance hydraulics during obturation, and the post-operative radiograph shows the non-surgical retreatment result and 3-dimensional obturation. In quick summary of the Gutta-Percha removal technique, access the tooth and prepare any coronal enlargement necessary. When using the rotary removal option, make a file selection and auger the Gutta-Percha material out of the canal. In the heat removal option, drive the selected heat carrier into the Gutta-Percha mass. Release the heat activating button and remove bites of Gutta-Percha a little at a time. In the headstrom displacement option, a headstrom file can be used apical to the heat carrier to remove the deeper material. In the file and solvent option, we use a series of files with chloroform to progressively wick the Gutta-Percha out of the canal. We finish with paper points and continue using paper points until they are observed to be clean, white, and dry. Endodontic obturation with silver points was first introduced during the 1930s. For decades, many dental schools taught the silver point technique, and as a result, thousands of clinicians obturated millions of root canals in this manner. Properly performed, clinicians achieved good results with this technique. Initially, our profession was impressed at how radiopaque these obturated cases appeared radiographically. Oftentimes, a false sense of security prevailed when observing radiodense silver wires moving through millimeters of underprepared canals. Regretfully, the apparent density of the pack did not confirm the thoroughness of the cleaning and shaping, and optimistically, round wires were expected to seal irregularly shaped root canal systems. A great number of cases obturated in this manner were underfilled, leaked, and failed. When there is a silver point failure and retreatment is necessary, it can be a challenge to eliminate these wires without a few tricks. Let's watch the silver point removal procedure. In dealing with silver points, it's critical to note you will encounter large, post-sized silver points, smaller wires utilized in more narrow canals, and segmented points where only the apical 1/3 is left in the canal to allow for coronal post space. Accessing teeth with silver points requires focus because silver points extending into the access chamber are the easiest link to the rest of the point harbored within the canal. If extra care is not taken in the access procedure, the points may be inadvertently foreshortened and become irretrievable. Many techniques have been developed for removing silver points, primarily due to their varying lengths, diameters, and the positions they occupy within the root canal space. Other techniques have been developed to remove split cone or intentionally sectioned silver points lying deep within the root canal space. Fortunately, most endodontically failing silver point cases can be successfully retreated utilizing just 1, 2, or perhaps 3 techniques. Steiglitz pliers are available in a 45 or 90-degree contra-angled configuration to enhance access into the pulp chambers of anterior and posterior teeth. Additionally, their distal ends can be ground down and modified, as shown on the right, to enhance access. When a segment of a silver point is encountered below the orifice and space is restricted, ultrasonics enhances the removal effort. Caution should be exercised so that ultrasonic instruments are not used directly on silver points because elemental silver is soft and rapidly erodes during the mechanical manipulation. Ultrasonic energy may be transmitted directly on a grasping plier with the Endo 1 to synergistically enhance the retrieval efforts. This form of indirect ultrasonics advantageously transfers energy along the silver point, breaks up material deep within the canal, and enhances the removal efforts. The discrepancy between a round silver wire and an irregularly shaped canal provides the clinician with an opportunity to use sizes 10 and 15 stainless steel hand files in the presence of a solvent. In a solvent-filled chamber, files are used lateral to the silver point to break up cements and to undermine and loosen the silver point for removal. In the headstrom displacement technique demonstrated in a plastic model, you can see how a headstrom is slid down past the silver point to about the junction of the middle and the apical 1/3. Because the silver point is soft, the headstrom can easily, when turned clockwise, bite and securely engage the silver point, and oftentimes the silver point can be elevated coronally quite easily. The post-removal system kit contains several component parts that may be utilized to mechanically form threads and engage the most coronal aspect of any silver point or intercanal obstruction whose diameter is 0.6 millimeters or greater. Specifically, the smaller sized taps provide possibility for the removal of certain silver points that extend into the pulp chamber. Traditionally, a technique was employed to remove an intercanal obstruction utilizing a spinal tap needle and an appropriately sized headstrom file. In this removal method, a properly sized microtube was pre-fitted so that it could be placed over the coronalmost aspect of the exposed obstruction. A headstrom file was then passed down the length of the tube until its flutes became tightly engaged between the obstruction and the internal lumen of the microtube. With experience and properly performed, this method of removal was quite successful. Presently, the microtube of choice is the instrument removal system. There are 3 IRS devices available, and each is a 2-component system designed to mechanically engage intracanal obstructions like silver points. The microtube's distal end contains a beveled and side window. The screw edge is passed through the proximal end of the microtube and upon contact is screwed down to mechanically engage the obstruction. Here we have 3 silver points extending coronally and being entombed in a core material. Surgical length round burrs are used to brush cut away restorative material. You can see as we progressively drill into the core, we want to be very careful so that we don't inadvertently foreshorten the heads of the silver points. I have found sometimes it's helpful to section the core mesial to distal to separate the tooth into a buccolingual half. Ultrasonics is a very safe way to remove remaining core material that's deep and entrapping the silver points. The great visibility provided by this instrument allows us to very carefully remove material. You can see as we change into a more hard type material, a glass ionomer, that it's critical to look for those silver points. Gently move the tip of the endo tube. Where the expected silver point would lie, you can see as it becomes exposed, we're chipping lateral to it and removing minute amounts of material in a controlled manner. Notice how the core material fragments and disintegrates when we get out on the leading edge and chip it away. Oftentimes you'll see the whole core start to loosen, and sometimes the silver point will even come out entrapped or entombed within the core. Work your way gently around the axial wall towards the palatal side and begin to free up that silver point. And as it becomes more visible, one knows where not to be, because we'd never want to use ultrasonics directly on a silver point. Silver points are soft, they're made out of elemental silver, and it's very easy to chew them up and have them actually vanish before your eyes. Sometimes I'll select a smaller profiled ultrasonic instrument to maximize vision as I circumferentially trough around the silver point. Firmly grasp and gently pull on the silver point to confirm its relative tightness. Sometimes a hemostat placed over the stylets improves removal technique. Many times on really short silver points, they're stubborn. Ultrasonic energy transmitted directly on the pliers synergistically enhances retrieval efforts. You can see in this instance how the assistant holds the ultrasonic device, an earlier version of the Endo 1, directly on the stylets. And here comes the silver point. Up, up, and away. We can always fulcrum against restoration or tooth structure, which will significantly enhance removal efforts. It's much better to fulcrum off of restorative or tooth structure than to simply pull just straight out of the canal. Appreciate that silver points are perfectly round and root canal systems are typically irregular in their cross-sectional shape. This discrepancy between the round silver wire and the irregularly shaped canal provides the clinician with an opportunity to use solvents and files lateral to the silver point. Start off by using sizes 10 and 15 files and progressively increase the file sizes. Sometimes even chelators are helpful to assist in slipping and sliding lateral to the silver point. If room exists, or if we can create room between the silver point and the canal wall, then what we're going to do is select a 35, 40, or 45 headstrom that we can fit into this space, and we'll use the flute angles to bite into the soft silver wire so we can facilitate displacement techniques. The headstrom handle then is turned gently but continuously in a clockwise motion to really get a good purchase on that silver point. The headstrom doesn't need to be placed around a curve deep, but can just be confined pretty much to the straightaway portions of the canal. A lot of times then it's difficult to pull the headstrom straight out of the tooth, so reverting back to something already discussed, we'll use fulcrum mechanics. And by putting the plier on restorative or tooth structure, we can actually lever and progressively move the silver point coronally. And in this case, it's pop goes the weasel. The occlusal view of this maxillary first molar shows a large silver point in the palatal canal. This is an ideal opportunity to use a microtubular tap from the PRS kit. A tapped and threaded and engaged silver point is extricated by hand, or if stubborn, removal is assisted with the torque bar, ultrasonics, or the Coronaflex. This is tapped on using a counterclockwise rotation. It's a reverse screw. One must be very careful when initially engaging the silver point and drawing the tap down over its coronalmost aspect not to over-tighten. We back the handle off a little bit clockwise and secure it and draw it down a little bit more to the counterclockwise direction and back and forth so that we don't inadvertently shear off the silver point within the lumen of the tap. A torque bar is selected and can be placed through the pre-designed spot in the handle, and this gives us a better engaging. Ultrasonics is a marvelous way to remove silver points, and you can see at the orifice level the disintegration and disruption of the cement during ultrasonic use. Simultaneously, the torque bar is engaging the handle to help pull and gently elevate the silver point out of the canal. You can see that this mechanical tap and thread device is a magnificent way to retrieve stubborn silver points. Here's a preoperative radiograph depicting an endodontically failing silver point case and a Gutta-Percha point tracing a sinus tract. In this photograph, we see the Endo 3 ultrasonic instrument removing material lateral to the silver point, further freeing up the silver point and getting it ready for removal. In the working radiograph, during the downpack, we can visualize apical and lateral corkage. The 5-year review demonstrates the three-dimensional endodontic treatment that promotes healing. This maxillary second molar is endodontically failing. Notice there's silver points in the MB and DB canals and Gutta-Percha in the palatal canal. We need to be careful when performing access, as we can see the silver points are extending up into the pulp chamber. This is the post-operative film. Notice straight line access, the fully shaped canals, and the palatal system apically is centered on the lesion of endodontic origin. A radiograph of a mandibular right first molar reveals a silver point in the mesial root that is coronally foreshortened and apically overextended. Because access to the silver point is limited, as seen in this photograph, an Endo 3 ultrasonic instrument is selected to brush cut away pulpal roof, thereby improving access to the silver point. This photograph shows the elimination of the overlying shelf of mesial dentin and the head of the fully exposed silver point ready for removal. We can now select a PRS microtubular tap to engage the silver point by turning the instrument counterclockwise. Note that over-threading can result in shearing off the point within the tap. A subsequent photograph shows the elimination of the silver point, and the post-operative radiograph reveals the non-surgical retreatment, a packed third mesial system, and corkage of 5 apical portals of exit. In this preoperative radiograph of an endodontically failing left central incisor, note the section silver point and asymmetrical lesion apically. A photograph demonstrates coronal and radicular access and shows the deeply positioned and exposed silver point. A subsequent working film shows a 35 headstrom bypassing the silver point and to length. The postoperative film demonstrates the significant hydraulics that is achieved utilizing the warm Gutta-Percha with vertical condensation technique. In this preoperative radiograph of a failing silver point case, note the internal resorption within the coronal 1/3 of the distal root. I removed the silver points with a microtube delivery device. A postoperative radiograph demonstrates the importance of straight line access, extended treatment apically and laterally, and the packed resorptive defect. To summarize the silver point removal technique, make careful access. Preserve the part of the silver point that occupies the pulp chamber, and if necessary, brush cut away dentin to further expose the point. Stygless pliers are then used to confirm the point's relative tightness, and the fulcrum-mechanical technique is utilized to remove the point. Ultrasonics may be applied to the styglets indirectly to facilitate removal. Peripheral filing in the presence of solvents creates lateral space to facilitate using a pre-selected headstrom file to engage and retrieve silver points. Tap and thread may be used with combinations of ultrasonics or fulcrum-mechanical techniques. At times, you may need to persevere through the various removal techniques so you can clean, shape, and pack. Obturation with carrier-based gutta-percha has emerged during the past decade and has continuously increased in popularity. When cleaning and shaping techniques are properly performed, this filling technique routinely packs gutta-percha into all aspects of the root canal system. When a canal is not properly shaped, the carrier can arrive apically devoid of gutta-percha and in direct contact with the dentinal wall. This finding is a reminder of the importance of canal preparation and the critical role it plays in success or failure. The obturators used to carry gutta-percha into the canals have evolved from metal to plastic. Generally, metal carriers prove more difficult to remove because their cutting flutes at times engage lateral dentin. Today, plastic carriers contain a longitudinal groove which will accommodate a file, which enhances removal. Additionally, it is useful to know plastic carriers less than size 40 are insoluble, but sizes 40 and up are soluble in solvents such as chloroform. A combination of gutta-percha and silver point removal techniques, which we have already discussed, will be utilized to successfully retrieve carriers. Let's watch. The techniques for removing carrier-based obturators are the same as has been previously described for gutta-percha and silver point removal. However, gutta-percha carriers pose additional challenges in that the clinician must remove both the gutta-percha and the carrier. As we saw earlier in the gutta-percha removal section, there are 3 heat transfer devices. These devices may be utilized to remove carrier-based obturators. Solvents will chemically soften the gutta-percha, which will allow smaller files to work lateral to the carrier, then progressively deeper, undermining and loosening the carrier for removal. Microdebriders can be useful in removing residual obturation materials from the irregularities of the canal systems. These flexible stainless steel instruments enhance vision due to their ergonomically designed offset handles. Microdebriders have efficient headstrom-type cutting blades. A carrier can be grasped with a plier and extricated by using fulcrum mechanics rather than a straight pull out of the tooth. This technique is further enhanced by first softening the gutta-percha with solvents or any source whose byproduct is heat. Rotary instrumentation can be used to effectively and efficiently auger a plastic carrier out of a canal. This should only be attempted if there is sufficient space to passively accommodate the rotary instrument without engaging lateral dentin. In the silver point removal section, earlier in the show, we saw a variety of microtube devices which can be utilized to remove intercanal obstructions. Likewise, these devices may be used to remove carrier-based obturators. As in silver point retreatment, access is critical and must be carefully performed to preserve that part of the carrier within the pulp chamber. Surgical linked round burrs are useful as it again kicks the head of the handpiece further away from the occlusal table. Carefully probe and check for the carrier. Ultrasonics is very, very helpful to thermal soften the gutta-percha. And you can see that we can actually pull it off the walls. And by pulling it off the walls, a smaller spoon excavator can be used to retrieve large amounts of gutta-percha. Once the gutta-percha has been removed, it begins to free up the pulpal floor, and we can more fully visualize the carriers in the various systems. Ultrasonics is very useful to thermal soften gutta-percha. Small, profile parallel-sided instruments are selected, like an Endo 3, 4, and 5, and they're carried sub-orifice level around the instrument. Notice as we gently tap down with the ultrasonic instrument, it displaces the carrier, which moves coronally. It's quite easy to reach in with pliers and retrieve these. This is the fun of retreatment. Following carrier removal, it's axiomatic that Gutta-Percha will remain in the canal. Rotary instrumentation is useful to retrieve this Gutta-Percha. Periodically inspect the tip of the file to determine if more Gutta-Percha remains deep. A heat carrier can be used lateral to the obturator to plunge into and thermal soften the Gutta-Percha. You can see the thermal softened Gutta-Percha allows us a number of opportunities that used synergistically can help retrieve carriers. We could place a headstrom, for instance, into this thermal softened mass to pull the carrier out. Ultrasonics, as has been previously described, can be used, and it's used in an indirect fashion. We can grab the head of the carrier with a Steigert's plier and use heat in conjunction to help thermal soften the mass to allow for successful retrieval. Again, rotary instruments are useful to bring Gutta-Percha coronally. Solvents are necessary then to allow us to do paper point wicking. Recall that we want to remove Gutta-Percha out of the fins and aberrations of the root canal system. And typically, as the paper points go in, you can see the solvent run up the point, which means it's depleted out of the canal. Continuously check the apical extent of the paper point until it comes out clean, white, and dry. Rotary nickel titanium files are one of the newest, most efficient methods to remove carrier-based obturators. In this technique, select a NiTi file that is smaller than the orifice it will be used in. Operating at approximately 600 RPMs, gently move into the Gutta-Percha. Friction thermal softens Gutta-Percha, allowing the file to advance apically. The rotating files flutes will engage the carrier and deliver it coronally. From a medical supply company, one can buy spinal tap needles, which is another microtube device that can be selected, sized, and placed over the coronalmost aspect of an obstruction like a silver point. Again, due to its positive rake angle, select a 35, 40, or 45 headstrom and insert it into the coronalmost aspect of the microtube. Pass the headstrom down the length of the tube until it engages itself tightly between the silver point and the internal lumen of the microtube. This mechanical method affords a significant purchase on many intercanal obstructions. A cotton plier can be placed under the hub to help in the coronal displacement technique. Turn the handle of the file clockwise to securely engage the obstruction, and this will enhance retrieval efforts. Nowadays, this procedure is simplified with the advent of the IRS. As we saw in the silver point removal section, peripheral filing is a most dependable method to undermine circumferential materials from a solid core. The tooth is topped off with chloroform, and small 10-15 stainless steel K-type files are used in a picking motion. Microdebriders provide phenomenal advantages to removing residual debris following shaping procedures. Notice there's no handle on these instruments. The clinician can place the file lateral to the obstruction and has unsurpassed vision when they look down the long axis of the instrument. Replenish the solutions frequently to provide fresh solvent. This fresh solvent is progressively carried deeper in the canal with small files, which continues to undermine cements lateral to the obstruction, freeing up the obstruction for removal efforts. Notice the flutter of the handle of the file. It can be supported with a plier so that it won't collapse and bend over in the chamber. Gently pick and stroke several times, constantly replacing with solvents. And now we can come in with a Steigert's to check the relative tightness of the obstruction. Notice how we're fulcruming off the tooth structure and up comes the plastic carrier. And sometimes we have to think on our feet, and in this instance we're winding 3 instruments, braiding them around the obstruction, enabling the files to be cinched down and around the carrier until tight. Live in the moment, be creative, and thinking on your feet can deliver results. This looks pretty traditional, but when we go to disassemble the tooth, we can see at higher magnifications, even up to 18 power, there's a deep obstruction in the palatal root. Ultrasonics can go in and generate heat and thermal soften gutta-percha, and that's an opening to begin to undermine this sectional plastic carrier. Work circumferentially in a counterclockwise motion, very light strokes. And solvents can top off the palatal canal, and small files are very useful in the peripheral filing technique to further gain access more deeply towards the terminus. The handle is checked for flutter continuously to know if we're engaging gutta-percha. We can inspect the tip of these instruments when they're retrieved to make sure we're tracking the canal properly. Every sequentially larger file is progressively removing gutta-percha, and it's undermining circumferential material, which allows the obstruction to be removed. You can see in this instance, it's floated up out of the canal, and a file identifies its successful retrieval. An endodontically failing molar bridge abutment shows the metal carriers entombed in an alloy core buildup and evidence of a second distal system. A postoperative radiograph demonstrates the retreatment efforts and three-dimensional endodontics. Here's a case obturate with carriers. Notice the Coke bottle preparations. The post-op film reveals three-dimensional treatment and the presence of an MB2 system. Reviewing the removal of carrier-based obturators, begin by making a carefully planned and well-designed access to fully expose the carriers. Ultrasonics can be used to heat soften gutta-percha circumferentially to the carrier. Gently tap the ultrasonic tip apically to liberate the carrier coronally. Remove residual materials by rotary and paper point wicking. The 5004 touch and heat, or System B, may be also utilized to soften gutta-percha. If the heat carrier sears into the plastic, deactivate, freeze the carrier to the plugger, and remove. Or a headstrom file can be placed into the softened gutta-percha, the flutes engaged into the carrier, and removed. Additionally, a plier engaged obturator can be removed by plunging lateral with a heat carrier. In the peripheral filing technique, solvents and small files are worked lateral to the carrier and progressively deeper into the canal, undermining the obstruction. Indirect ultrasonics can be utilized and applied directly on a stygless plier to facilitate removal. In the rotary nickel titanium technique, files mechanically soften gutta-percha, engage the carrier, and auger it out. In the microtube delivery technique, we can utilize a tube, like a spinal tap needle in this case, or the IRS, to go down the canal and over the carrier. Pass the headstrom through the tube, engage the carrier, and remove. Additionally, we can use tap and thread techniques to remove the carriers. Remember, carrier removal requires us to, at times, reach deeper into our bag of tricks to accomplish the task. The history and controversy surrounding paste fillers is fascinating. Originally, this method of obturation was used for those patients who couldn't afford conventional endodontics and was considered a benevolent alternative to extraction. Great controversies arose between paste users and non-users regarding standard of care, cytotoxicity, treatment predictability, and long-term success. Regretfully, countless cases were unsuccessful, and too often the magic paste was used to overcome deficiencies in canal preparation. When evaluating a paste case for retreatment, it is useful to clinically understand that paste can generally be divided into soft, penetrable, and removable versus hard, impenetrable, and at times unremovable. Typically, the whitish color paste used in the United States remains soft within a canal and is readily removed. Notoriously, the reddish-brown resin paste used in Russia, Eastern Europe, or the Pacific Rim poses formidable challenges in removal as it sets up brick hard. When a paste case fails, The significant retreatment challenges are safe canal negotiation and avoiding the displacement of toxic materials periapically. Let's take a look. When evaluating a paste case for retreatment, it is important to understand that the densest portion of the paste in a canal is usually coronal due to the method of placement. In general, the paste material is progressively less dense moving apically. At times, if a clinician can penetrate through a brick-hard paste material just 1 more millimeter, then the file will oftentimes be able to go to length. There are a variety of techniques that may be utilized to remove paste fillers. Retreatment of paste-filled cases is often wrought with surprises, as clinicians frequently encounter calcifications, resorptions, and post-visit flare-ups. These clinical and post-treatment events should be anticipated and communicated so the patient is well informed. Stainless steel O2 tapered hand files can potentially create a pilot hole for safe-ended Nitai rotary instruments to follow and effectively auger the paste material coronally. Here's the trick I like to use when the paste within a canal is brick hard and hand files cannot penetrate and create the necessary pilot hole. Modify the tip of a rotary Nitai instrument with a transmetal burr to establish a cutting end. With this tip modification, exercise caution because in-cutting files can deviate and false path find. Ultrasonic instruments, in conjunction with the microscope, afford excellent control in removing paste from the straightaway portions of a canal. Specifically, the Endo 3, 4, and 5 zirconium nitride-coated ultrasonic instruments may be used below the orifice to remove brick-hard resin-type paste. To remove paste apical to a canal curvature, a pre-curved stainless steel file is attached to a specially designed adapter which mounts on and is activated by the ultrasonic handpiece. Here we see that when the handle of an endodontic instrument is removed, its shaft can be secured in the ultrasonically activated file adapter. It is important to note that this method of use should only be performed in paste-filled canals that have been first secured with small stainless steel hand files. Solvents like Endosolv E and R can be helpful to chemically soften hard paste. The E designates the solution for the removal of eugenate-based paste, whereas the R is the solution for resin-based paste. The selection of a particular solvent is oftentimes by trial and error. Appreciate it takes longer to soften paste than chloroform to soften Gutta-Percha. After removing paste fillers and shaping and cleaning the canal, it is axiomatic that residual paste will still be noted within the irregularities of the root canal preparation. As seen earlier, microdebriders are specially designed instruments to precisely remove residual materials from a root canal system. In this maxillary molar, let's remove the paste from the palatal canal with an end-cutting rotary instrument. Let's take a look. When you're using rotary into a canal, use them as prescribed by manufacturers. Don't push any harder than you would if you were to write with a pencil without breaking the lead. But the end-cutting tip will begin to dig into the paste, and the Stropco surgical irrigator blows out the dust that's generated. This whole procedure is done dry. Now there we are hitting that void. You can see how the instrument falls into the void and through it and past, and it's now working progressively deeper in the canal. Continue rotary removal until the flutes are clear of paste debris. Now fill the chamber brim full with either Endosolv E or Endosolv R. The selection of a particular chemical is by trial and error, and appreciate that although these pastes are miscible with these chemicals, it takes longer to soften paste, for instance, than chloroform to soften Gutta-Percha. Flood the tooth with these solvents. The one that you choose will be the one that you notice activity occurring. Keep wicking with paper points and begin to appreciate that over a little bit of time, the paste begins to soften and goes into solution. This is observed clinically by increasing amounts of material noticed on paper points. The case is now ready to clean, shape, and pack. Piezoelectric ultrasonics with a number 4 parallel-walled instrument provides an excellent view to remove paste from the straightaway portions of the canal. The principle of optimizing ultrasonics energy is to use a light touch and let the natural amplitude of the tip disintegrate the material. Therefore, it is important not to over-enthusiastically force the instrument into the canal, but rather let it naturally walk itself in. Piezoelectric ultrasonic instruments work in a linear motion, which means the tip predictably follows an in-and-out path, which allows for us to safely track grooves. When we disassemble teeth, it's not unusual to find extra grooves, which typically roadmap us to a second system. We have to be very observant of this during disassembly procedures. Hold the ultrasonic instrument gently, and because of the linear motion tip, watch the material disintegrate and break up. The Stropco surgical irrigator provides a controlled stream of air to evacuate this material as we progressively move in a more apical direction. The ultrasonic instrument is very, very efficient at removing materials in the straightaway portions of the canal. One may have to periodically switch to a smaller instrument to work deeper within the middle 1/3 of the root. Microdebriders are used to remove residual material that tenaciously clings to the internal aspects of the canal wall. The canal walls can be dressed up with this instrument, but typically rotary instrumentation provides an opening now to work deeper without obstruction to properly track and follow the canal to remove material. It's useful to look at the working end of these instruments to see if we still have material clinging to the flutes. Irrigation procedures followed by wicking is typically necessary to remove the material and liberate it from the canal. For a variety of reasons, rotary instrumentation can't always reach the end of paste-filled canals. Ultrasonically activated files may provide deeper access by removing paste around canal curvatures, but even this sometimes has limitations. So we use chemicals, Indosol V or Indosol R, and small K-type stainless steel pre-curved files to work the apical 1/3 where pathways of curvature are usual. The instrument is picking gently into the canal so that we don't inadvertently push or inoculate toxic materials periapically. Now you can see in the recleaned mesial buccal and distal canal that everything is ready to go, but here's a perfect example of expect the unexpected. You can see within the MB system that there's some grooving off towards the ML, and the Explorer is pointing to the expected ML system. Here's a preoperative film of a failing mandibular first molar. Notice the ill-fitting crown, paste extending slightly subcrestally, and evidence of multiple canals. There is frank apical pathology. The postoperative film reveals fully shaped canals and complete treatment. A recall film demonstrates great endodontic healing. Regrettably, the post space was not fully utilized in the distal root, and the pin in the mesial root is dangerously close to the furcation. This paste-filled maxillary first bicuspid exhibits incomplete treatment and apical pathology. The postoperative film shows successful retreatment with each canal packed to its respective terminus. Here is a preoperative radiograph of a paste-filled mandibular left second molar that exhibits post-treatment disease. Note the extra distal lingual root. A 10-year recall film demonstrates the connection between treating multiple apical portals of exit and osseous healing. Here we have a mandibular second molar bridge abutment. Notice the ill-fitting restorative, a silver point in the mesial system, paste in the distal, and furcal and apical lesions of endodontic origin. When endodontics is properly performed, there is the inevitability for bone fill and long-term success. Let's review the paste removal technique. The tooth is reaccessed in a normal manner. Modify a nickel titanium rotary file tip to penetrate brick-hard paste. Remove material progressively in a coronal to apical direction. In the ultrasonic technique, an appropriately sized Pro Ultra Endo instrument is selected to remove paste from the straightaway portions of the canal. To remove paste in the curved portions of a secured canal, use the ultrasonic file adapter with a pre-curved stainless steel file. In the file and solvent technique, select the appropriate solvent. Pick through and penetrate the paste with small stainless steel files until patent. Use microdebriders to remove residual paste materials from the canal. Irrigate with the right solvent. Wick with paper points to encourage complete paste removal. Now these canals can be reshaped to facilitate three-dimensional cleaning and filling. If for any reason the procedures outlined in this show do not accomplish the intended result, and in the presence of clinical symptoms or radiographic pathology, surgical intervention may be necessary. Earlier in the tape, I promised to share some endodontic statistics that will empower you. Let's hear what I said about this in a presentation in Los Angeles recently. If you believe that success rates are 90%, oh, let's see your hands. How many people think you're about 90% successful? Now, this is probably a fairly accurate survey, because as I go from state to state, we do the program, almost every hand would go up if you said, what is your success rate? Do you expect it to be about 90%? And that's because we were told that. And that's because it all appeared in the Washington study. The Washington study was done by John Engel in 1951 and 52. It was conducted by postdoctoral students doing lateral condensation in an era where our shapes were more conservative and much more parallel. We probably weren't clean as well. The lateral condensation wasn't developing the hydraulics. And so they reported, though, at the end of a 2-year time frame that success rates in endodontics were 93.8. Let's call it 94. So at 94%, you could be pretty successful. What was never conducted was, and published, it was conducted and unpublished, was what happens at 5 years, what happens at 7 years, what happens at 10-year timeline horizons. Regretfully, success rates plummeted to about 50% at 10 years. Now remember, this was done 40-some years ago. So when you think about 90% successful, I have never believed that, because what was always missing was time. There's been, regretfully, very few studies that have been done much more than 2 years. Most of them have been done at 6 months. Personally, I believe all endodontics works for 5 or 6 minutes. What is the reciprocal failure rate if 90% is indeed represents success? Well, if we're talking 40 million, 10% of 40 million is 4 million. How many dentists are there in the country? About 150,000. If you throw out pedodontists, periodontists, oral surgeons, academicians, semi-retired, don't do endo, don't care, you could say that there's about 100,000 dentists left that do everyday endodontics. What's 100,000 into 4 million? Can't do the math? It's a lot. It's 40 cases. It would be very conceivable if you were a general dentist to pick up a survey and be able to look at years of new patients arriving in the office, hold up those surveys, and you would probably spot a tooth that had been previously treated, probably 40 times in a year. You would be looking, and there may be a fistula, there may be a quiet lesion, there may be some expansion of the cortical plate, there may be some percussion, there may be some mobility. There may be something breaking down with the periodontium that makes you a little suspicious. Now that is 40 cases in 1 year alone. If one looks back then over 40-some years where hundreds of millions of cases were treated, you can see there's a lot of retreatment out there. So our future is indeed bright. Now that you can see the extraordinary possibility of retreatment, we need to focus on an action plan so you can get on the path and begin the journey towards endodontic mastery. Remember, it's not the destination, but the journey that makes you more than you were. Their master's journey is composed of 5 steps. Training. Get first-rate instruction, either one-on-one or in small groups. Remember to see the teacher, look at the student. Practice. Masters love to practice, and because of this, they get better. And the better they get, the more they love to practice. There's an old martial arts saying, stay on the mat 5 minutes longer than your opponent. Surrender. Learning new skills sometimes involves certain indignities. Surrender means giving up your hard-won proficiencies to get to a higher level. Intentionality. The mental game of any discipline involves dedication, perseverance, mental toughness, and love. Visualization and seeing yourself perform great retreatment is a critical step in the journey. The edge. Playing on the edge is a balancing act and requires awareness to know when you're pushing beyond safe limits. The essence of all masters is to perform within your abilities. Speaking of the edge, it reminds me of a story. Many years ago, I found great joy training in a form of martial arts known as Taekwondo. I fondly remember the eagerness I felt to be on the mat and practice endless repetitions. Upon entering this dingy, sweaty, and unpretentious studio, a plaque could be seen on the wall. I recall the words today as clearly as when I first read them over 25 years ago. The message was about overcoming fear, exploring possibility, and being your potential. The inscription on the plaque read, "Come to the edge." No, I can't. Come to the edge. No, I'm afraid. Come to the edge. No, I'll fall. During this tape, you came to the edge. I gave you a gentle push, and you flew away. Thank you for your time and willingness to learn. I look forward to visiting with you in the next episode of Ruddle on Retreatment. I wish you a safe endodontic flight and great future success.
Amapola, l'oiseau léger qui passe, la rose et le lilas chantent ta grâce. Amapola, dont tous les cieux se mirent, n'a pas autant d'éclat que ton sourire. Le vent me t'apportant le poème que je lui ai confié ce soir.